Pediatrics Part 1. I'm going to cover this first part of pediatrics. I guess the first thing you have to remember about pediatrics is children aren't just small adults. Children differ anatomically, physically, and emotionally from adults. Children enter this world as sometimes neonates ranging from less than 1 pound to 5 pounds, which would be that regardless of gestational age, that 5 week or that 5 pound break below 5 pounds would be considered preemie according to your book. And children and then neonates above 5 pounds could still be a preemie if they're below 36 weeks of gestational age. We've been through all of those things in neonatal assessment, so we're going to move on past that. But all of that to say that babies enter this world as very small little ones who require complete care. They are essentially helpless and depend on those around them for everything. And childhood ranges from that first year of life as an infant to then toddler, which would be up to 3 years of age, and then from 3 to 6 would be a preschool age child, then school age, picking up at 6, and then at puberty, that child becomes an adolescent, and that continues until age 18. So pediatrics runs the gamut. As pediatrics move through adolescence, they become more and more like adults as they reach full sexual maturity, reach, for the most part, their adult height and the features of adulthood. But let's go through some of the differences, some of the illnesses that children are susceptible to at various ages, and even how they respond to us as EMS providers. Very small babies, they don't know stranger fear yet. And so everything's great. They tolerate us pretty well when they're small infants, and then they hit maybe around 6 months, and we are strangers, and maybe by then they have some unpleasant experience with healthcare providers. If nothing else, just giving them immunizations for vaccine preventable diseases, and it can be quite traumatic to them to have an encounter with us, and we have to be sensitive to that, and we have to find ways where possible to work around that. Something as simple as letting a parent, a grandparent, whoever their caregiver is, a babysitter who they're with all the time, let them hold the child while we do our jobs. So just small things like that can make a big difference in dealing with pediatrics. Over time, you will gain clinical experience, and you will better learn how to approach children of different ages and how to care for them, how to assess them, how that assessment might differ from age to age. With young children, we start off, we're communicating with family, with caregivers, and not with the child. And then as that child ages, we need to remember to not speak about them as if they're not present while we're doing our jobs. That can undermine any trust that we're building, any rapport we're building with that child, and it can cause our clinical interaction with them to be less productive and more traumatic for them. So things we can do while still providing good patient care, things that we can do to help keep the child calm is going to work to our benefit, and over the course of our interaction with them, it's going to work to that child's benefit. If we can reassure the parent and keep them calm, that's usually going to at least help result in a calm child. If we act in a manner that is unprofessional, or we are just totally freaked out and we cause that parent to be agitated or scared, or we're accusatory and confrontational toward that parent, which sometimes you feel like being, but you can't do that. Part of this word over here, professional, that is you, and you have to be the healthcare professional in the room. You have to be empathetic toward the feeling of the parent and toward the feeling of the child. Over this entire course, we've talked about our role as being as that of empathy, as far as our interaction with patients and patients' families. We can appreciate that they are stressed, that they're upset, that all the way up to they have just suffered a sudden, unexpected, catastrophic death in their family, or they're afraid that they're going to lose someone in the situation we're dealing with. We can be empathetic to their feelings. We can be reassuring where we can, without trying to give false hope. Where we cross the line and take on their feeling and emotion, and we become emotionally upset, that is where our professionalism and our ability to do our jobs will suffer, and our patients will suffer because of that. So empathy, yes. Sympathy, no. I can tell you that even the most hardened, crusty old EMT or paramedic out there will find a large streak of emotion in a catastrophic encounter with a pediatric patient, where there is just grievous injury, loss of life, horrible child abuse that maybe doesn't result in death, but it results in just life-changing, debilitating injury to an innocent child. And our emotions can range from deep anger. I'm not saying that's unjustified, but we have to manage it, remain professional, and to just being emotionally devastated when a little one dies. That's not inappropriate. That is appropriate after the call. You can't let patient care suffer by allowing yourself to be emotionally devastated. So that's a little aside from this, but I think it bears that little sidebar discussion. Don't try to carry the weight of the world on your shoulders after you run a call and you see a young patient die, and that it can weigh on you. I have known of EMTs and paramedics who have taken their own lives eventually over the cumulative effect, and others who have had suicide attempts because of the cumulative effect of the old stuff it and forget it, suck it up, go on, that's part of the business mindset. Don't go there. through your employer, there's a means to find somebody to reach out to get help yourself. So don't ignore that. That's a big part of some of these situations you're going to encounter with pediatrics. Okay, back where we should be instead of over there on my sidebar. I've just seen too many bad things happen to folks great clinicians who walk away from the business because it just gets to them. If you're pursuing a goal and a dream here, don't let that take you out of it. Just get some help. Okay, and watch those around you. And if you know that one of your coworkers has run a tough call on a pediatric patient, then reach out to them. Keep an eye on them. Watch, see if they change. See if they're having a problem. So we're one big dysfunctional, crazy family out there, and we have to take care of each other. There's nobody else to do it. So just an unbelievable amount of physical and emotional changes from birth to age 18. I would venture to say that very few of us remember much of anything, maybe flashes of memory in our preschool years, but from the time that we have just good, solid, concrete memories up until the time we graduate from high school, just think of all the changes that we go through. Think of all the changes you've been through. That's just amazing changes. Let's make sure that I didn't miss any of the preschool, any of those developmental age ranges, and it doesn't look like I did. Okay, infancy, first year of life. So, and that begins at the first month, because that neonate period is from birth to 1 month. So that's a distinction. I'm sure not going to throw it at you on my exam, but it's something that I can't see it coming up on your national registry, but I guess it could. Okay, what do babies do? Babies eat, they sleep, they drink, they poop, and they repeat. And they spend up to 16 hours a day sleeping, and it seems like, for those of us who are parents, it seems like they don't spend enough time awake and interacting with you. I guess it's cool to cuddle a sleeping baby, and great time as a parent. Great time with other people's kids too. I'm one of those guys who loves babies. Babies mainly respond to physical stimuli. They say, I don't entirely believe this, but your book says they can't tell the difference between parents and strangers. Babies know their mothers, especially if baby is a breast baby and mom is lactating. If nothing else, they know mama because of that, and they know mama at mealtime. I think they know their parents, but your book says they can't tell the difference. Okay, crying is their way of interacting with the world. That is their means of expression. That's how they tell us if they hurt, if they're wet, if they need to have their diaper changed, if they're in pain because of a diaper rash, if they're hungry, they cry. And sometimes they don't have to have a reason to cry. They just cry, and you just can't console them. They can have a temper, and they just want to cut loose and scream and cry for a while, and there's not much you can do about it. Okay. Basic needs of that infant, or especially early, food, warmth, and comfort. We can soothe them by holding them, cuddling them, rocking them, talking to them. You can babble. You can in a sweet tone of voice recite the Gettysburg Address to a baby, and they'll be happy to hear it. Sometimes that will soothe them. If you have a baby and you're preparing for a national registry in just that sweet parent voice, you can just read your class notes to them. You can engage baby in studying for the national registry or for your in-class EMT exams. Suckling reflex, rooting reflex, those are built-in reflexes to help baby feed. You can stroke a baby's cheek. In fact, it's a neurologic thing that you will, when someone is assessing an infant, especially a newborn, you will see them stroke the baby's cheek. A lot of times, what does baby do? Baby tries to turn their mouth toward whatever it was that just stroked their cheek. What's the purpose of that? Trying to get baby to find the breast to latch on and feed, and baby feels something on the cheek, thinking it's a nipple, and turns toward it. So that would be a rooting or and then suckling reflex. Head control is limited. Don't forget to control baby's head. You talk about a quick way to lose the trust of a parent and sometimes be the target of a young mother's ire is if you take baby and you don't control baby's head and they look like a bobblehead doll. Don't do that. Just take the baby, control the baby's head. We know how to do that. If you don't know how to do that, find someone with a baby and get them to teach you. All right. Babies are predisposed to hypothermia. Their temperature regulatory system is underdeveloped. They lose tons of heat through their heads, as we all do, but they lose lots of heat through their heads. So we swaddle babies and we cover their heads to keep them warm. Okay, and we need to explain when we need to assess an infant, we need to explain to the family who has carefully bundled up their infant that we need to uncover the baby so that we can assess the baby, assuring them that we will bundle their baby up and we won't let their baby get unnecessarily cold while we examine them. That's just, again, part of being a clinician, and you have a tiny little patient in front of you, but you may have a room full of other patients being the family. So we need to explain what we're doing before we do it. Okay, 2 to 6 months, more active stage. They interact with you more. They start to smile. They're awake longer. They make eye contact. They start to recognize those around them. That suckling reflex is extremely strong. They have active extremity movement. They jerk their little limbs. They kick their feet when they're happy, and they have a vigorous cry. Talk about the active extremity movement, because if you find a flaccid baby who is not moving arms and legs and activity level is low, we need to investigate and find out why. If baby has, when stimulated, doesn't cry or has a very weak cry, we need to assess for life threats. Make sure that that baby is breathing well, moving air well, and is being oxygenated and perfused well. They may follow objects with their eyes, just as a pediatrics nurse taught me this trick, but just as a way to help me assess a baby, I used to keep a tied up little some bright red yarn, and I kind of tied a knot in the end, and I would move that across an infant's field of vision to see if they tracked that, if they followed it, if got no reaction from that, then I needed to investigate and determine if that baby had altered mental status. Was their level of consciousness compromised, and try to ascertain what was causing their level of consciousness to be compromised. It's also a visual assessment to assess their vision, and that, I mean, just keep that in your shirt pocket, and it's a real quick thing to pull it out. Doesn't take a bunch of time, and it helps assess that level of consciousness of one that you're just not certain where they fall on that AVPU scale, which we use in infants. When we get down to part 2 here, we'll see that. Okay, they use their hands to examine objects. They're kind of clumsy about doing it. Getting on toward that 6 months, maybe they can start to hold a bottle, that kind of stuff. Some of you who are parents would say, boy, my kid wasn't in this 30%, or they were in the 30%, they weren't in the 70%, because it says around 70% of infants sleep through the night by 6 months. It's kind of a bittersweet thing. You love having your cute little baby, and when they start sleeping through the night, oh man, they're starting to grow up on me. Then what comes next? You will run this call, almost guaranteed, maybe more than once. You're called to the scene, to a residence. You have a panicked parent, or maybe even a panicked babysitter, who had a baby who was 3, 4, or 5 months old, and baby couldn't roll over yesterday, and maybe baby couldn't roll over this morning early, and give baby a bath, or whatever they're doing with baby, and they place baby on the bed, and they turn around to do something, and they come back before they come back, they turn around to do something, and they hear thump, and baby rolls over, falls off the bed. They discover baby has reached a milestone, rolling over. They have also reached a milestone of having a child fall from a bed onto the floor. I'm sure that there are babies who are injured in falling off a bed. I have never had one that I found to have a serious injury from it. Almost every time, despite my reassurance, we transported those babies. They were assessed in the ER and then released, and without injury. That's what we pray will be the outcome. I'm sure there are little ones who have been seriously injured by rolling off a bed or off of a couch or a chair. So persistent crying, irritability, lack of eye contact, those can be indicators of serious illness, depressed mental status, delay in development, and sometimes it's just that the baby just won't quit crying. So we have to, and it's tough for us, because how often do we run a call on an infant and get to fully assess an infant, and how comfortable do we feel doing that? It's tough. I will tell you that as a very experienced paramedic, and who runs calls day in, day out for years, you don't have that much experience in assessing infants. So despite what one of us might say, deep down we've kind of got a little knot in our stomach when it comes time to run that infrequent pediatric call, let alone that very infrequent infant call. So study hard. Don't let this be the end of your pediatric education. If nothing else, my motivation has always been, I don't want to be the cause of something bad happening to someone's child because I don't know what I'm doing. So that's That's been a motivation for me to get lots of extra education. Okay. By their first year, infants should say their first word. Many of them are saying quite a few words by the time they're a year. If they're not saying any words by a year, that's something that has to be investigated. It could be that they're just delayed in their speech, but it could also be that they have hearing issues. They have cognitive issues. So it's something that needs to be investigated. And if a child is having regular well child checkups, then their pediatrician or pediatric nurse practitioner is going to be tracking those milestones and looking into those things. The thing is, we don't always get those patients who have those well child checkups and all of those things. And then somewhere between 6 to 12 months, they start to crawl, then they start to walk, and then they start to run not too long after that. It seems like they go from standing and taking their first step to running wide open in a very short period of time. Somewhere between 6 to 12 months, an infant starts teething. That can be a traumatic time. It's very painful. I always figured it must be like chewing on a thumbtack, because it seems to be very painful. And a child who's teething, an infant who's teething, they can run a low-grade temp. They can have a little bit of diarrhea with it, and that can be traumatic for a first-time parent who hasn't been through that before. And during this time, as they become a little more mobile, they're like a puppy. Don't let me hurt your feelings, but they're like a puppy in one regard. They explore the world with their mouths. So they're at a higher risk of choking, and will, in part 2 of the pediatric lectures, we will look at the anatomic differences in the pediatric upper airway and see why they're much more prone to choking than an older child or an adult. And then poisonings. If you have a little one, crawl around on the floor and look for things that they can get into, and including houseplants. And don't if you run a call on an infant and you feel like the chief complaint might be poisoning, or there's just illness with no explanation, start looking around the house for house plants, things like poinsettias, those pretty red or green plants that we have around Christmas. Those are highly poisonous to, I guess, to all mammals, but I know to kids and to dogs and cats. So don't have those in your house. Get the plastic ones. And around Christmas, there's brush up on poisonings by poinsettias, so you can recognize that if you're called to a sick child and it might be a poisoning. Separation anxiety. I separate an infant in this age range from a parent or a caregiver that they're very familiar with. They cry, and they are difficult to console. They also start to they have that stranger fright in there. We're strangers, we're unfamiliar. We eventually, possibly in our assessment and transport, we have to take them from the person that they're clinging to and looking to for reassurance. That can be traumatic for them. It can be traumatic to our ears because they may cry unconsolably. Also, crying and irritability can be a symptom of a serious illness. So is that child crying because they're separated from their caregiver briefly, or is it because they're in pain or they're seriously ill? That can be difficult to ascertain at times. I would recommend trying to, if you have to take that infant from that caregiver and to place them on your stretcher or wherever you put them, whether it's on your cot or whether it's on the couch in the house or the bed, try to position the person they're familiar with so that they can see them. Sometimes that helps a little bit. Sometimes it is no help at all. Okay. Initially, when we assess an infant, we observe them from a distance. What's their level of activity? Are they crying? Do we have a flaccid baby lying there who appears to be very ill? I call that the through the door or across the room assessment. That's so before you ever get to them. Let the caregiver hold the baby while you're doing your physical assessment, unless there's just no way that you can do it, or if you're down to the point that you're having to deal with choking, or if you're having to do CPR. Rub your hands together, warm them up. Don't touch them with your cold hands. It's a little harder with gloves on, but you can still do it. The bell or the diaphragm of your stethoscope, warm that up on your hand. And anything that's going to be painful as far as examination or treatment, if time permits, try to move that to the end of your assessment process. Otherwise, you're going to have a baby who's crying, and you can't do a good job of assessing them. Okay, toddler. So infancy to 3 years. So hit that first birthday until the third birthday. That child is a toddler. In that time, rapid growth and development. Man, they start to walk, they start to run, they open doors, they fall downstairs, they crawl over baby gates and fall, they open drawers, they get into everything. And they don't understand cause and effect relationships, so they're fearless little creatures, and that can get them in some really bad situations that can result in some serious injuries and even death. They're impulsive. The kids beside you, this morning, driving up my street, there's a lady pushing a stroller, and then there was a toddler, probably close to 18 months, and she was letting that toddler follow her down the sidewalk as she was pushing a stroller. Cars going by, just whizzing back and forth, and oh man, I almost wanted to drive with my eyes shut. I just almost couldn't watch because I was afraid that kid was just gonna run off that sidewalk and into the street in front of one of those cars. And I seemed to be the only one slowing down, other than the ones behind me, and they were out of luck because they had to slow down. Okay, it's not uncommon to have a toddler of this age get away from even an attentive parent and or caregiver, and just for a moment, and run in front of a car or something. I personally ran a call where older children were supposed to be watching a toddler about that 18-month age at this house that all these kids were outside playing, and the bigger kids started doing what bigger kids do. They started playing, and the father of all these kids, and there were a bunch of them, he came out to get in his pickup truck and go to work, and he got in his truck and backed up, and he backed his pickup truck over the head of his 18-month-old infant, who crawled under the pickup. I don't know if to hide from the other kids or just to see what was under there, and just was lying there with his little head behind the back wheel of that pickup. And man, those stick with you. I don't care who you are. Those can be rough. Okay, they start to learn body parts: eyes, nose, mouth. We can make a game of assessment. Eyes, they say eyes, and you show them your light, and you're going to look in their eyes, because we need to assess their pupils. Try if you can make a game of assessment, unless you have a critical kid where, we're moving and we need to be off that scene, and if we have a little more time, we can make a little game of it. It's the best we can. Sometimes that won't work. They just scream, but you can try it. Okay, they start to speak. They may not chew their food real well, and there are these things called grapes. They fit perfectly down in a toddler's airway, and they'll plug that off, and can be difficult to get out. Or you take jumping ahead a little bit, you take a 4 or 5 year old, 3-year-old, and a hot dog, and a piece of a hot dog. That is an airway obstructor too. Okay, 18 to 24 months, language development begins to be rapid at that point. Cognitive ability really increases. They start to understand a little bit of cause and effect. They still do very impulsive things that still scare you to death. Balance and gait start to improve. They run, they climb. Some kids love to climb. They'll climb everything in the house, and then they fall off, and then they get to meet us. You may be, if they have a favorite toy, they have a stuffed animal that they love, we may be able to use that to help us get them to cuddle with their favorite stuffed animal while we do our assessment. Sometimes that can help. Let's see. And then that stranger anxiety even increases more with toddlers in this age range. They will cling to a caregiver, and you almost can't peel them away if you have to take them and you get one little hand off and then the other one grabs, and it can be really tough. And we need to communicate with the caregiver during that time, get them to work with us, not against us. They have a really hard time describing pain, obviously. If you ask them, what's your pain on a scale of 0 to 10, with 0 being no pain at all, 10 being the worst you ever felt, that means nothing to them, or they don't know what 0 or 10 are. So we have to use the Wong-Baker FACES scale. So have that with you somewhere, and maybe when they're toward the upper end of this range, maybe they can point to how bad they feel, or when you touch whatever it is that hurts. Let's get somebody to try to distract them as you do your physical examination. We're going to do a toe-to-head assessment. When we monkey with their heads, we make them mad and they scream. So start at the foot, move to the head. Persistent crying again. still with this age can be a symptom of serious illness or injury, as can the toddler who is so sick that they don't cry at all. So somewhere in between is preferable. And then previous bad experiences with other healthcare providers can make them very afraid of us. Okay, 3 to 6 years. Language, they can use language very effectively. Man, if you've ever been around very many 2-year-olds, less than 2, maybe, around 2, there's one word they know really well. No, it's not the F word. It's no. They know no. No, 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 no. Everything is no. Can I look in your eyes with my light? No, but I'm going to do it anyway. So we make a game of it. Don't ask them if you can look in their eyes. Don't ask them permission to do anything. They're going to say no. But if we can make a game of it, if we can distract them, it's going to go better. Man, 3 to 6 years. I used to coach little kids in baseball. I was amazed at how some kids at 5, can hit and throw a baseball. My son at 6 could knock the cover off of a baseball, and he and I were watching a ball game when he got up from his nap one day, and he was in my lap, and one of the ball players, Mark McGuire, years ago, he blasted a home run, like one of those upper deck shots, and my then little boy said, "Daddy, can I hit a ball like that?" And I said, "God, I hope so." That's he didn't hit the point where he could hit a ball like that, but he could hold his own. Man, it was a blast having kids. A lot of work too. All right. Toilet training eventually is mastered somewhere between 2 and 6. Boys take longer than girls. 3-year-old boy who's not toilet trained, it's not a great big deal to anybody but the parents who think he should be toilet trained by then. Okay, they do have rich imagination. They can be extremely fearful about pain. As you progress to your advanced EMT after this course, and then to your paramedic, don't say things like, I'm going to give you a shot. Shot, they think of you're going to shoot them with a gun. That's you say things like, I need to put medicine under your skin, and I have to poke a hole in your skin to do it, and it's going to hurt, but I need you to be real still for me. Be honest with them. Tell them if it's going to hurt. If there's something that we're going to do as basic treatment, we need to tell them that it's going to hurt. Don't lie to them. That's just not what you do. You lose their trust, and you're going to have a very bad experience for the entire remainder of the time that you're treating that little patient. Okay. They in this age range, 3 to 6, and the closer you get to 6, the better they are at understanding directions and at describing where they hurt, and being able to take their hand and put their hand on the place that hurts the most. And we can't use this great vocabulary that you've built over the course, your time in this EMT course. You can't use that. You have to use very basic language with most of them. We still need to get our history from their caregivers. A 3 to 6 year old child who's a preschooler is going to be a very poor historian. Anything we can do to engage their imagination while we examine them is going to work to our benefit and theirs. Again, don't lie to them. Try to distract them. assess from the feet to the head. Don't start head to feet, because if you mess with their heads, you still, when that 3-year-old, you're going to make him mad, make her mad, and you're not going to get a whole lot of assessment done after that. All right. Kids think Band-Aids will cure anything, so if it helps to stick Band-Aids on them, you can get more Band-Aids. And explain to them at the ER when you get there, and this 4-year-old has 15 Band-Aids stuck on him. Everywhere that you touch the kid when you were assessing them, you said, okay, I'm going to put a Band-Aid here. Or then, I mean, sometimes that works. If it's a critical area that you're going to need to assess over and over, then don't stick a Band-Aid there so that you can't see. But that's part of playing a game to assess a patient. Still, modesty is developing, but we need to keep the child covered. If kids in cardiac arrest and you're doing CPR, that's different than if the kid fell and mom's afraid, dad's afraid the kid has a broken arm. Okay, 6 to 12, over that time from 6 to 12, kids start to emulate adults. They want to try to act more like adults, or they want to try to act like the adolescents that they see who are older than them and they idolize, or their favorite people on their shows that they like to see on the Disney Channel. I don't know. They're going to try to find people to emulate. All right. They begin to interact with you more as you're getting a history from them. They can interact with you again, not utilizing your full medical terminology and all the vast medical language skills that you've developed. But school is important to them, if nothing else, to see their friends, and they want to go play and they want to go be with people who are like them, the little monsters on the playground, other kids. It's who they want to be with. They don't want to spend all their time with their parents. As they approach adolescence, they want to spend less and less time with their parents, and that becomes stressful for us as parents. They start to understand death. They may have had friends, family members, little classmates who have died. They start to understand death. And then, unfortunately, more and more as the years go by, it seems that even early school age kids, 6-7-year-olds, will occasionally commit suicide, and that is extremely traumatic for everybody. They start to understand death, but they may not yet comprehend the permanence of death. As they progress through those school age years, we start to assess them more like they're adults, knowing that there are developmental differences and differences in illnesses that kids are susceptible to. Sorry about that. We need to gain their trust. We need to talk to them, not just the caregiver. If we cut them out of the conversation, we're going to lose them. So we can start at the head and move to the feet with assessment now. Give the child some choices if you can during your assessment and transport. What do I mean? Do you want to sit up or do you want to lie down? I'm going to take you to the hospital on my bed here that goes in the back of my ambulance, but do you want to sit up or lay down? Not, do you want to go to the hospital with me on my stretcher, or do you want to go to the hospital with me on my stretcher? Or that's a given. They don't have the choice in that. But hey, I'm going to take you to the hospital, and I'm going to give you a ride on my bed that rolls here. When I put you on there, do you want to lay down or you want to sit up? Oh, okay. Do you want to unbutton your shirt yourself so I can take my stethoscope and listen to your chest? Okay, not will you let me listen to your chest? Oh, will you? Do you want to unbutton your shirt so I can listen to your chest, or do you want me to do it? That's those kinds of things. You have to think ahead, and you have to. Experience will help you there, but those kinds of things would help. Do you want, after they're old enough that we're taking a blood pressure, not will you let me take your blood pressure? I'm going to put this thing on your arm that hugs your arm. And do you want me to put that on this arm or that arm, pointing to the left arm or the right arm? That's okay. Don't argue with them. Don't debate with them. It's going to happen, but give them some choices like that, unless they're critical and we don't have time, and then we got to go. All right. We can let them listen to. If you let me listen to your heartbeat and listen to your lungs, then I'll let you listen to your own heart. Would you like that? No. Okay. Or you could tell them, after I listen to your heart and listen to you breathe, then I'll let you listen to your heart. All right. You can give them a simple explanation about what's causing their pain. You hurt your arm really bad, and we're going to have to take you to find out if something is really hurt on the inside there. I think that's what is making your arm hurt. I'm going to put this little ice pack on there. That should help. Okay? And then I'm going to put the ice pack on there. If they say no, I'm still going to put the ice pack on there. Tell them this should help it feel better. It's cold. Yeah, it's cold. That's how it's going to help it feel better. It's going to be really cold, but let's see if it helps it feel better. Okay? I don't know. Just communicate with them. 13 to 18, if you remember back, and it's a long time for me, if you remember back to adolescence and early adolescence, adolescents are very self-conscious about their bodies, the changes that are happening to their bodies. We need to be cognizant of that. We need to if possible, let a same-sex clinician assess them. We need to, of course, not pull a young girl's shirt up and then leave the shirt pulled up. If we don't have to pull the shirt up, we don't need to visualize and inspect anything. Do everything you can with their clothes on. And if you have a male and female crew member, if you have a female EMT and this is an ALS call, and you have a male paramedic, you may have a problem and you have a critical patient. It isn't always feasible to let the female crew member always be the one who examines the young adolescent girl versus having a male examiner. Do the best you can. There are some rough situations out there in EMS, and we do the best we can. Don't ever be careful. And I used to say, be careful examining an adolescent of the opposite sex, because you don't want to be accused of doing something improper. So you need to have some sort of witness available. That is not just limited to the opposite sex anymore. Both sexes can be accused of sexual assault during a physical examination. It's going to be extremely rare that you're ever going to need to inspect the genitalia of an adolescent patient, and you need to have some kind of witness there to who has your back when it comes to any sort of allegation that might be made against you. And if you do have to examine the genitalia, then you need to document who was there with you and exactly what you did. All right, enough of that, but you have to be careful. If you're in jail, you can't take care of patients anymore. Okay. Oh man, adolescent risk taking, especially with boys, but some with girls. Some adolescent risk taking is to impress friends or others around you. Some is to draw attention to themselves and say, "Look at me, I can do this." Some of it is to engage in conduct that they know their parents would not approve of. The adolescents often feel indestructible, and I mean, though 10 feet tall and bulletproof, and man, they do some risky, crazy things, and then we give them this 3,000 or 4,000 pound thing on 4 wheels that you put gasoline and stick a key in, and we turn them loose, and then they do risky things. Males tend to take more risks than females. That is because the prefrontal cortex of the brain isn't fully developed, and it develops later in boys than in girls, or in males than in females, however you want to say it. And that is part of the source of some of that risky behavior. Okay. Some of that risk taking can result in severe trauma and death, risky sexual practices. Teen pregnancy, we spent plenty of time talking about teen pregnancy and how we separate an adolescent girl with abdominal pain. We need to separate from parents or caregiver so that we can get a sexual history and try to determine if there's a chance that patient might be pregnant. Okay. And then other things, drug and alcohol use. If we ask in front of a parent, we're not going to get an honest answer. If we ask in private, we might not get an honest answer, but there is a better chance. Okay, that ends part 1 of pediatrics. We'll shut it down there.